So, hello friends. So, I'll be just giving a very brief overview on this very important topic, infective endocarditis. So I'm sure most of my intensive care friends would be listening to this since MBBS days. So, this is in the context of one of the interesting case we saw recently in our ICU, and the antibiotic regimes that I would be talking on is based on 2023 European Society of Cardiology guidelines. So it's this is the latest guidelines that has come. Basically, when you look at the antibiotic regimens for endocarditis, it comes from American Society of Cardiology and European Society. American Society is the older one, which hasn't been updated. The latest one is from 2023 European Society of Cardiology. So it's good to have a little bit of a clarity on the drug dosing. So the context setting is we had a 37-year-old gentleman who came to our ICU as a COVID. He came as a COVID with shortness of breath, and echo was done. So we did an echo for this patient. So this is what it showed. So if you see, there is a nice vegetation. So at the aortic valve, so it's a LVOT here. So you can see there is a, if you see very carefully, there is a vegetation there sitting at the LVOT, at the aortic valve. So he had a severe aortic regurgitation. So this patient who comes with a tentative diagnosis of endocarditis, then echo shows acute regurgitation, acute aortic regurgitation with a suspicious vegetation. And for around 12 hours, so there was not much mind put into this aortic regurgitation. And they didn't actually say it's a vegetation, although there is a suspicion, is what they had mentioned. Then we look into his leg, which was nicely covered because he wouldn't expose the leg. So this gentleman had this very quite a bad non-healing ulcer in the left leg, and he was not showing this. So he was quite an educated gentleman. So then the blood culture came as gram-positive cocci. So now you can put all the jigsaw. The guy who came to ICU with a infiltrates in the lung, calling it as a COVID, then echo reveals severe aortic regurgitation with a suspicion of endocarditis, suspicion of vegetation. Then the leg gets seen after around 8 to 10 hours, and we see this also because he wouldn't show his leg. And then the blood culture comes positive with a gram positive cocci. So that is the clinical conundrum that this patient comes with. So we put everything together. So it's an infective endocarditis, and the source of infection is this non-healing ulcer in the leg. So that is the whole story that gets unfolded. So we'll just look into the epidemiology of infective endocarditis. Most of the listeners would know if it is endocarditis, predominantly it will be gram-positive organisms. So if you look at the epidemiological, 31% constitutes Staphylococcus aureus. So either it can be methicillin sensitive Staphylococcus or MRSA. 17%, so this is how the staph and strep look. 17% are caused by Streptococcus pneumonia. So it can be, we'll talk about different species of strep viridans or non-viridans, so on and so forth. And the cons, which is coagulase negative Staphylococcus, constitutes 11%. And Enterococcus comes somewhere after this. So that the most common organism is Staphylococcus, followed by Streptococcus, followed by cons and Enterococcus. So our patient, this patient with a non-healing ulcer, had Enterococcus faecalis in the blood culture. So that is the epidemiology of endocarditis. And I'm sure from MBBS days, we have been reading about major criteria and minor criteria. They pretty much remain the same. So the major criteria is where you have at least 3 blood cultures positive and 2 blood cultures which are positive 12 hours apart. And major criteria also includes echo evidence of having vegetation, or you have a root abscess, so or you have a valvular abscess or acute regurgitation with a suspicion of vegetations. So any echo features which are suggestive of vegetation becomes major criteria. So two major criteria, you would call it as a diagnosis of infective endocarditis. So 3 blood culture positive. If echo is not showing evidence or one is not clear, so CT of the heart or the cardiac CT also is a tool that could be used as one of the criteria. Or if it is one blood culture, if it is a Coxella Burnetti, so this is how the Coxella Burnetti looks. So one blood culture Coxella Burnetti with the IgG titers of more than 1 in 800 is also considered as one of the major criteria. Or if for some reason echo you are not able to do, CT does not show, so radionuclide imaging of the heart showing evidence of the PET CT. So FDG PET CT showing evidence of endocarditis or the hotspot like this can be considered as a major criteria. So these are the major criteria. If you have two of these criteria, either blood culture with echo, if echo you are not able to do cardiac CT, if cardiac CT, if it's a FDG PET. So any of these constitute major criteria. So that's about major. So I will tell you, if you have two major criteria, you would make a conclusive diagnosis of endocarditis. So when you look at minor criteria, so one should have predisposing factors. So if you have had any valvular disease, if you have had mitral stenosis or aortic stenosis, any of the abnormal bicuspid mitral valve, so on and so forth, if any of the pre-existing valvular conditions are present, so any predisposing factors or IV drug use, so on and so forth, any of the pre-existing trigger is present can be taken as minor criteria. Or you have to look at features of systemic embolization. So our patient had splenic infarct. So if you have abscesses, this is a spleen. So if you have a splenic abscesses, splenic infarct, or if you have mycotic aneurysm, or if patients presents with stroke, with vegetations, so they constitute. So any features of systemic embolizations or subconjunctival hemorrhage or Janeway's lesions. So Janeway's lesions look something like this. So these are all due to systemic embolization. So any of these criteria which are present, one has to at least look for any of these. So our patient had splenic sort of an infarct. So if someone comes with stroke or subconjunctival hemorrhage or Janeway's lesion, or if you have some sort of a spondylolisthesis or some sort of a spondylitis, that also comes as a characterization of the minor criteria, and fever more than 38 degrees. So these are some of the minor criteria that you can pictorially keep in back of your mind. So then there are other immunological phenomena which also constitute minor criteria. So someone having glomerulonephritis or these Osler's nodes or rot spots in the eyes, or blood cultures, not necessarily three are positive, so one may be positive, or rheumatoid factor positive. So these are all constitute the minor criteria. So you would have been familiar with all these criteria, but you have to categorize as systemic embolization and immunological features. So what constitutes definitive endocarditis? When you have to call someone as definitive infective endocarditis, it should be two major. Two major is blood cultures being positive, or you have this echo evaluation with one minor, or one major with three minor criteria, or five minor. So any of these criteria, you can call it as definitive sort of endocarditis. Possible diagnosis is like our patient had two major, which is blood cultures being positive, echo evaluation showing endocarditis or a vegetations, and obviously he had a splenic infarct. So possible is one major plus 1 to 2 minor or 3 to 4 minor is possible endocarditis. So that's about the whole diagnostic elements. So we'll jump into mainly the focus of this presentation, major minor criteria you would have been reading from MBBS days. So we'll focus a bit on antibiotic current accepted regimes from the ESC guidelines 2023. So when we talk about treatment for endocarditis, they're broadly divided into two phases. The first phase is the intensive phase, where antibiotics generally are given for 2 weeks in combination, generally for endocarditis, and it has to be bactericidal. And most important for our patient, the whole reason why we had to deliberate on the literature is about the surgical intervention, because this patient has had severe aortic regurgitation. We need to have clarity when would we do surgical intervention, whether you would complete the course of antibiotics and do surgical intervention, or one has to consider surgical intervention in the acute phase. That was the question that we had for this patient. So if you look into the latest guidelines and literature, the suggestion is the surgical option should be considered within the 2 weeks in the acute phase. So surgery has to be considered, especially when they have severe aortic or some regurgitation lesion or abscess or valve sort of a dissonance that has happened, or the lot of valve destruction that has happened, surgery. So our patient did not improve with medical management, with antibiotics that we gave, and within 3 to 4 to 5 days, cultures did become negative and he was taken up for aortic valve replacement. He improved and we discharged him home. Otherwise, he was needing NIV, he was needing a lot of medications to optimize his preload, afterload, so on and so forth. So this is an important message for all my intensive care friends. Someone comes to ICU with infective endocarditis, who is in unwell with regurgitation lesion. You start antibiotics, and then you would have to consider, because when this patient came to ICU, once we made a diagnosis of endocarditis, we involved the cardiac surgeons upfront, and they were involved on a daily basis, and they looked at the optimal timing. When things stabilized a little bit, cultures became negative, he was taken up for surgery, and he remarkably improved and discharged home. So the surgical action has to be considered within 2 weeks is the message that I think all intensivist friends should keep in mind. The second phase is 4 weeks. So if you ask the duration of antibiotics, or for a simple bug like Streptococcus, there is some sort of a signals or direction that you can give 4 weeks. But for most other organisms, it is 6 weeks. 6 weeks is antibiotics. So 2 weeks is intense phase. 4 weeks is where generally preferred is IV. If patient has a very stable endocarditis, you can consider oral after the source control with valve replacement is done. And this 4 to 6 weeks is to prevent relapse and to eliminate all the dormant organisms that may be present. So for all practical reasons, 6 weeks is the overall course, but there are certain situations like uncomplicated endocarditis caused by oral Streptococcus organisms. 4 weeks is acceptable. I'll talk about what the guidelines say. So as I said, and any endocarditis, we divide into native valve. NV is native valve endocarditis and PV is prosthetic valve. For all prosthetic, it is 6 weeks. And for all non-strep, it is almost always 6 weeks is the course of antibiotic regimen. And we'll go through what the guidelines say. So when you look into the recommendations, so we'll talk about only three organisms: Streptococcus, Staphylococcus, and Enterococcus, because these are the three ones which we tend to deal with. When you talk about Streptococcus, they are broadly divided into Streptococcus from the oral cavity and Streptococcal from the non-oral, which is Galolyticus or Pyogenes are from the non-oral. If you talk about oral Streptococcus, these are the species. So it's good for all ICU trainees to know these species: anginosus and downy, mitis and mutans, and sanguinis and salivarius. Salivarius is easy to remember, comes from saliva. So these are the Streptococcus organisms which come from the oral cavity. So when you look into the recommendation for this Streptococcus, which is a straightforward bug, duration of therapy is 4 weeks. So if you see most of the recommendations, I'll be showing in this tabular format. So this is the antibiotic and this is the duration. This is the dose and this is the level of evidence. So if you look into the recommendations for oral Streptococcus, any of these species, it is penicillin G, 12 to 18 million units per day, to be divided into 4 to 6 doses. Level of evidence is 1B. Or you can give amoxicillin, 12 grams per day, 4 to 6 divided doses. Level of evidence is 1B. Or easiest for ICU is ceftriaxone, 2 grams per day. Level of evidence is 1B. And only in Streptococcus from the oral, if you are dealing with any of these mitis, mutans, salivarius, if you want to curtail the duration to 2 weeks in an uncomplicated, then you can add gentamicin, which is 3 milligram per kg per day, 2 doses, maximum up to 240 mg per day. If you combine ceftriaxone 2 grams per day with gentamicin in uncomplicated, you can give for 2 weeks. Otherwise, it's always 4 weeks for Streptococcus. And if they're allergic to beta lactams, sometimes they can be allergic, then the recommendation is vancomycin, 30 milligrams per kg as 2 doses. Level of recommendation is 1C. And native valve endocarditis, the duration is 4 weeks. So keep as practical reasons 4 weeks. If you want to cut it 2 weeks in non-complicated in Streptococcus, you can add gentamicin if renal function is normal and you can use it. Otherwise, for all practical, it will be for 4 weeks. And if it is a prosthetic valve endocarditis with allergic to beta lactamase, then you have to add vancomycin with gentamicin for 2 weeks, followed by vancomycin. So the vancomycin is 30 milligram per kg as 2 doses, as a divided dose, and with gentamicin is 3 mg per kg per day as 2 divided doses. Level of recommendation is 1C. So basically, in prosthetic valve endocarditis Streptococcus, duration is 6 weeks, where you combine vancomycin with gentamicin for 2 weeks, followed by only. So that is the initial phase. And then the second phase. The first phase is always intensive where you give combination, followed by vancomycin 30 milligram per kg as two divided doses. When I say two doses, don't read it as 30 milligram per kg two times a day. It is in two divided doses we give. So if it is 60 kgs, so you basically it's 2 grams, 1 grams twice a day we give. So that is for 4 weeks. Totally it is for 6 weeks. This is for who are allergic to beta-lactamase. So if we are dealing with methicillin sensitive Staphylococcus looks like bunch of grapes, so that's the morphology. So if you are dealing with methicillin sensitive Staphylococcus aureus, NV is native valve endocarditis. You can use flucloxacin 12 grams per day in a divided doses of 4 to 6 doses. Recommendation is class 1B recommendation. Strong 1B is basically strong recommendation with a moderate level of evidence, and duration of therapy they put it as 4 to 6 weeks, but preferably I think it would be good to go to 6 weeks. Or if you're not using flucloxacin, the easiest is to use cefazolin 6 grams per kg. Sorry, 6 grams per day it is, it's not per kg, as a 3 divided doses. So 1B recommendation for 4 to 6 weeks. If it is a prosthetic valve endocarditis, then one has to combine with flucloxacin. A prosthesis, it's simple, you have to add rifampicin because of the biofilms that forms. So flucloxacin 12 grams per day, 4 to 6 divided doses, plus rifampicin is 900 mg per day, 3 divided doses, and gentamicin is 3 mg per kg per day, 2 divided doses. Level of recommendation is 1B for 2 weeks. After 2 weeks, you have to continue. You can stop. So all the acute first phase, you add gentamicin for 2 weeks, and after that, you reduce it to flucloxacin with rifampicin for 4 weeks. And the dose is 12 grams per day and 900 mg per day. So this is, so for all prosthetic valve, it has to be 6 weeks. And for prosthetic valve, generally rifampicin is added to remove to penetrate the biofilm, and gentamicin is added for 2 weeks. And if it is methicillin sensitive Staphylococcus aureus who are allergic to beta-lactams, then one can consider cefazolin 6 grams per day in 3 divided doses. Strong recommendation with a moderate level of evidence, 4 to 6 weeks. If it is a prosthetic valve endocarditis, again, as I said, you will add cefazolin with rifampicin with gentamicin for 2 weeks, followed by only cefazolin with rifampicin for 4 weeks. So it's very simple. Don't get too confused. You can go through these slides, or you can take a picture of these. So if it is prosthetic valve, it's always 6 weeks. Add rifampicin and add gentamicin. Most of the endocarditis, gentamicin is added for Staph aureus for 2 weeks, followed by the maintenance phase or the second phase where you only give one antibiotic, cefazolin with rifampicin for prosthetic valve. So if it is MRSA, so in native valve endocarditis is vancomycin. Because it's MRSA, you can't give any of the cephalosporins. Vancomycins 30 to 60 milligrams per kg per day, 2 to 3 divided doses. Strong recommendation. Duration of therapy is 4 to 6 weeks. If it is prosthetic valve with vancomycin, you add rifampicin and gentamicin for 2 weeks, followed by vancomycin with rifampicin for 4 weeks. So that is the dose. So if it is MRSA, which is we know is a deadly bug, so the recommendation is higher dose of vancomycin, because generally it's 30 mg per kg. 30 mg per kg is around 2 grams. So in MRSA, in severe endocarditis, they go up to 60 mg, which is 4 grams, 2 grams twice a day, essentially for 60 kg males, and then maintenance with vancomycin and rifampicin. So that's about, so we spoke about Streptococcus is the simplest sort of a antibiotic usage where you can use up to 4 weeks. But after Streptococcus, Staphylococcus, almost always it is for 6 weeks, where intensive phase for prosthetic valve, you add gentamicin with rifampicin, followed by rifampicin and whatever antibiotic is suggested. So now we'll go to Enterococcus faecalis. Our patient had Enterococcus faecalis. The duration of therapy for all endocarditis, as I said, for staph and Enterococcus is always 6 weeks. For Enterococcus faecalis, it is 6 weeks. So for Enterococcus, the recommendation is native valve endocarditis who are beta-lactam sensitive and who are sensitive to aminoglycosides. So HLAR is non-high level aminoglycoside resistance. So they have to classify Enterococcus faecalis is high-level aminoglycoside resistance versus non-high-level aminoglycoside resistance. So if it is a non-high-level aminoglycoside resistance, so the recommendation is you give amoxicillin 12 grams per day in 4 to 6 divided doses for 6 weeks, along with ceftriaxone. For Enterococcus faecalis, it's amoxicillin with ceftriaxone for 6 weeks and plus gentamicin. So three drugs to be given for 2 weeks, followed by amoxicillin plus ceftriaxone for 6 weeks, or ampicillin with ceftriaxone for 6 weeks. So this is the combination for someone who is sensitive to beta-lactam. So it has to be ceftriaxone with ampicillin, ceftriaxone with amoxicillin for 6 weeks, and ceftriaxone with ampicillin with gentamicin for 2 weeks, followed by 4 weeks of ceftriaxone with ampicillin. So don't get confused. So it is 4 weeks of three drugs, gentamicin, ceftriaxone, and ampicillin. And after 2 weeks, you give 4 weeks of ceftriaxone ampicillin or ceftriaxone amoxicillin. So that is for native valve. If it is Enterococcus faecalis with high level aminoglycoside resistance, then the combination of amoxicillin with ceftriaxone or ampicillin and ceftriaxone for 4 weeks or for 6 weeks. Because it is aminoglycoside resistance, you don't add aminoglycoside for this. If it is aminoglycoside sensitive, you add aminoglycoside gentamicin for 2 weeks and then this combination of ceftriaxone. So for Enterococcus, it has to be combination of ceftriaxone with ampicillin, ceftriaxone with amoxicillin. If it is gentamicin sensitive, add gentamicin for 2 weeks in that first phase. So that is the suggestion or recommendation by European Society. And if it is beta-lactam resistant, because our patient had beta-lactam resistance Enterococcus faecalis or BRE, beta-lactam resistance, then you have to add, ours was not BRE, it was beta-lactam resistance. So you have to add vancomycin with gentamicin for 2 weeks, followed by vancomycin for 4 weeks. So this is the recommended sort of a combination. You have to add gentamicin for 2 weeks, followed by vancomycin for 4 weeks, totally 6 weeks. So you add gentamicin for 2 weeks, then you give vancomycin for 4 weeks. If it is VRE, vancomycin resistant Enterococcus, then you have to add daptomycin 10 to 12 milligram per kg as a single dose for 6 weeks, along with ampicillin 10 to 12 milligram per kg per day for 6 weeks. Or you can add daptomycin with fosfomycin 12 grams per day for 6 weeks, or ertapenem 2 grams per day for 6 weeks, or ceftaroline. Since ceftaroline is not there, I have not put it in this. So this is for BRE. So as you see, friends, these dosages is hard to remember. So obviously, when you're treating a patient with endocarditis, at least have some clarity that there are two phases of therapy. The first is the first phase or intensive phase, where generally recommendation you would have combination with gentamicin or with any of the drug. And then the maintenance phase will be with one drug. But most antibiotic regimes, as you would see, is for 6 weeks, except Streptococcus, where you can limit it to 4 weeks. So our patient had beta-lactam resistant Enterococcus faecalis. So the regime possibly that we would adopt is vancomycin plus gentamicin for 2 weeks, followed by vancomycin for 4 weeks. The patient has completely recovered. All the cultures are negative, and currently he is completing the course of antibiotics. So this is the guidelines. So I would upload this on a YouTube. So go through this, and any of this, I wouldn't expect you all to remember exactly the combinations, but at least have a broad sort of an understanding about the first 2 weeks is the intensive phase, where generally the combination is preferred with gentamicin and followed by 4 weeks of maintenance where you would be using single antibiotic. If it's a prosthetic valve, so you would add with gentamicin is more often preferred with an antibiotic along with rifampicin for 2 weeks, followed by the next combination with rifampicin and whatever drug for next 4 weeks. So that's about it, folks. So request you all to submit your valuable work to Journal of Acute Care, and of course, you can visit my website to refer to this lecture. So thank you. So I just focused more on the recommendations part on the latest guidelines. And of course, the diagnosis you would have been aware, and just remember those pictures, major and minor criteria. So that's all is there in infective endocarditis. So thank you, one and all.